Madam, should we start?
Yeah, we can definitely start, sir.
Yes. As such, the recording will be there, and those who cannot join, we will send them the recording. There is no issue, absolutely. So, dear learners, you're all welcome to today's session. Today is the you know third day of this spell, CHCWM counseling spell, and today we have a very important topic for discussion, that is on integrated infection prevention and control management. And to talk on this particular topic, we have requested Dr. Sumita Soni, a senior academic counselor of IGNO of CHCWM program, as well as a senior professor in Department of Microbiology of BJ Medical College, Ahmedabad, uh, to take this session, and she is right here in front of us. We are very happy that she has agreed, and she would talk to you on this particular topic. Madam, you are welcome to this session, and I request you on behalf of the university to take the session and reply to the queries of all the learners if there is any. So learners, please listen to Madam carefully, and at the end of the session, you can ask questions. Do not intervene in between, because it will distract the presentation. So you are all requested to ask your questions towards the end of the session. So thank you very much, madam. Please take over.
Okay, sir, my screen is visible, sir?
Yes, your screen is visible.
Okay, sir. Okay. So very good afternoon to all of you. And as yesterday also we have met for one of the important topic, that is the pre-treatment of the biomedical waste. And today I'll be taking you through the infection prevention and control, basic guidelines as an integrated approach. And I would also like to mention that today is the World Hand Hygiene Day. Okay, 5th of May, we all celebrate it worldwide as a World Hand Hygiene Day. And to your surprise, if I mention it and I'm not wrong in that the hand hygiene itself is able to prevent uh, 60% of the infection which is occurring in a healthcare setting. Okay, so having said that, I will take my topic forward, and the major thing which we'll be learning today will be how the infection is spread in a healthcare setting, and how we all, being an infection prevention champions, being a biomedical waste management champions, we are able to prevent the spread of transmission of all these infection. So HAI, if I say, see, we never wanted to be in a hospital like this. The photograph I have shown, that when whatever the hospital, and if I talk about my own hospital, it's a government setting, it's a purely government organization, it's a quaternary hospital, and it is a very busy hospital, like 5,000 OPD cases, 1,000 cases are admitted in the hospital every day. In the wards, people are running here and there. So there are all chances that you can catch, or a patient can get infected with any of the infection which is either in the environment, or it is transmitted by any of the healthcare workers. So our job is to prevent this healthcare associated infection, and to do that we have to do it in a logical way, we have to do it in a scientific way, and we have to do it in such a way that it is outcome oriented, and the outcome will be speaking about, or the indicators which are made for this will be speaking about how much successful we are in our infection prevention and control practices. So what is a healthcare associated infection? It is basically, it occurs to a patient during the process of the care in a hospital or a healthcare facility, and which was not previously there. So it was previously referred to as nosocomial or hospital acquired. But now we cannot, make a term like acquired. We usually, omit this term, or we don't want to speak about the word acquired. Rather, now it is called as a onset. Okay, community onset, hospital onset, or healthcare facility onset. infection, because we don't know whether it has been acquired in the hospital or not, but definitely we know that after getting admitted in the hospital it has proceeded further, and the patient is getting infection. So it also includes the occupation. So it speaks a word about us also, that occupational infection among all the healthcare provider is a part and parcel of healthcare associated infection. So basically what happens, why this infection occurs? So there is, in the, I don't know how many of you are from the medical background, but though you are from, definitely you are from a healthcare background. And when we talk about a healthcare infection, it basically occurs with the epidemiological interaction, and this is called as the epidemiological triad. So what happens to infection to occur? We need to have a agent, organism चाहिए, bacteria चाहिए, virus चाहिए, okay? Environment needs to be there, and definitely a person or a patient, a host, which we say, it can be us also, it can be a patient also, it can be a patient relative also, but basically we talk in a healthcare setting about a patient only. So intrinsic host susceptibility, its age, its status, nutritional status, its all comorbidity, its severity of underlying diseases, these all are, flourishing and nourishing this healthcare associated infection. We need to have an organism which is definitely in a healthcare setting, it is multi-drug resistant organism, and it incubate into that setting. And also environmental factors are there, like patient is on immunosuppressant drug, patient is already on antibiotic, patient has gone for a certain operations. Okay, so these are all, when these three things come together, they will be causing an infection inside a healthcare setting, and that is called as a healthcare associated. We deliberately speak it like associated and onset. We have now omitted the term acquired. Okay, so acquired word is now not a current. With down the line, we have changed the terminology to the healthcare associated and or healthcare onset. So this is basically the burden of HAI, and you can see India also in this picture. Neonate and pediatric more than 10. So you can see the red dot and the orange dot in this picture, at least for the India. Okay, so this is the laboratory study. It is a lab confirmed data, and it is talking about this. And this has all been published in the National Guideline for Infection Prevention and Control 2020. Together with the guidelines of the biomedical waste management, probably I'll be sharing the national guidelines, IPC guidelines also to you all, so that we are at the same platform, we are learning the same standards, and we are also implementing the same standard to prevent the healthcare associated infection. So, healthcare associated infection is a concern to everyone, and 7 out of 10% of every 100 hospitalized patients are HAI. 7 in the high income and low and middle income. Like if we talk about India, it is 10% are healthcare associated. It's 1 in 4 of healthcare associated infection is in the long term acute care setting, and it is caused by the multi-drug resistant organisms, and also a third patient in the ICU is affected by the healthcare association. So it's a grave situation, and we need to be alert. So why it is important? So why it is important. So there are two facts about the infection prevention and control, that when we talk about the healthcare associated infection, it is inevitable to find a hospital without a healthcare associated infection. Along with that, it is also a true fact that all the healthcare associated infection are largely preventable through the effective IPC measures. Like I talked about, today is a hand hygiene day. If we observe the hand hygiene religiously in all our healthcare areas, in all our clinical areas, in patient care areas, it is going to curtail down the rate of infection by 60%. Okay. So HAI has a most common adverse event during the healthcare delivery. It's a public health concern, and it is prolonged stay. It leads to the morbidity, disability, multi-drug resistant organism. And not only this, if there is a single member earning in a family, you all know that it is also a cost to the family, and this family member will not be able to go to his job, as well as it will be an additional cost to the health system also. So we are pooling all the resources, targeting all the resources toward treating these patients. So important, it's also when we talk about the National Patient Safety Implementation Framework of internationally and nationally, then there is one important pillar, very important pillar, is the control of healthcare associated infection. Okay, So HAI in detail will be talked to you about later on after my session is over. What are the HAI, different type of the HAI? I think another counselor has been assigned this task, and madam will be taking you through all the common type of the HAI, how we measure it and all. So this is not right now in my domain to explain you, but it is the part of the National Patient Safety Implementation Network. It's also important priority under the AMR containment. So AMR, like we are a network lab for the national program on containment of the AMR. AMR is antimicrobial resistance, and there also one of the strategy is infection prevention and control. So anywhere you go, yesterday somebody asked me, do we have a biomedical waste management committee? Please do have a HICC committee, that is a hospital infection control committee, and the subcommittee can be a biomedical waste committee, or infection prevention control committee can take you know it can take care of the biomedical waste management in across the entire hospital settings. So how a how we can target to reduce a healthcare associated infection. So as I told you, if you remember that triangle, one important thing, that these three part of the triangle, susceptible host, infectious agent, and the reservoir was there in the triangle. We need to also know how it entered in a susceptible host. We also need to know how it is transmitted from one susceptible host to other, or one healthcare worker to the patient, and how it exit. Okay, why we want to know this chain of transmission? It is very important, because the entire thing is revolving around this chain of transmission, and our job as a healthcare professional is to break the chain of transmission. So anything and everything you do should target this. Okay. If I talk about the infectious agent, it is rapid and accurate identification of the organism. If you identify them in the laboratory, like microbiology laboratory, if you know which antibiotics are effective, you can, in the right doses, right strength, for the right duration, you can give the antibiotic and kill the organisms. Okay. So it will be no more they are present in the patient to transmit to the another patient. Okay. Reservoirs, like if we talk about our table, chair, cot, bed, everything is an entire environment surrounding the patient care setting will be contaminated, will be flourishing and nourishing all these bacteria, so those who are antimicrobial resistant, every day in and day out. So if you all have heard about the guidelines of the disinfection, so Swachhata Mission has given a very good guideline, and depending upon the priority, okay, depending upon the priority of the clinical areas, we can clean that areas by the environmental sanitation. Okay, we need to also take care of the employees' health, and we need to disinfect and sterilize whatever we are using for the patient care. Okay, so reservoir, we need to have a very good disinfection protocols in place. And I am not wrong if I say that entire IPC guideline, which is raised by Ministry of Health and Family Welfare, developed by Ministry and Health and Family Welfare for the entire country, and we have been trained for the training of trainers also regarding this. I will be sharing you that guideline so that we all know how and what to do and how to go about it. Okay. So the environmental, so the critical areas, we need to define our areas as the critical, semi-critical, and the non-critical. So like admin office are the non-critical, ICUs are definitely critical, OT are definitely critical, okay, wards are semi-critical. So depending upon that, our sanitation protocols need to be defined. Portal of entry, so proper attire need to be there. Like if we are, portal of entry can be when you are breaching the skin of a patient, what will happen? What will happen? So why we don't do it in a open? We are doing it in a we are doing it inside the hospital, inside the operation theater. So the entire environment of this is also controlled. So OT environment is a positive pressure environment, and it is a part of infection prevention control to make it a positive environment so that bacteria do not enter. And wearing the personal protective equipment, proper OT surgical attire, hand washing, and whatever the waste generated, we need to discard it appropriately. Okay. Control of the secretions and all, we need to take care of it. Okay. Then the means of transmission, definitely the hand washing, here I have shown you The hand washing is a very important tool for breaching the transmission of infection. Sterilization, disinfection, airflow control in the OT. Okay, isolation of the patient. We all have heard about the COVID-19. We all had faced the COVID-19 pandemic, and we all know that COVID-19 pandemic, these were all, it was an infectious disease. It was transmitting like anything. It was airborne, and we isolated the patient with the full isolation facilities. Portal of exit, we all know it is a aseptic technique. We have to, so if you are doing a wound care, so wound itself, the pus itself may be a source of infection, catheter, wound. So we need to have a proper, personal protective equipment being worn, and we need to disinfect these sites. Okay, and then susceptible host, no one other than, so we all don't catch infection. This can come to your mind, that everyone and anyone is not catching the infection. So who are catching the infection, who are getting infected through this infection? They are only those who are susceptible to it. So we can treat their underlying disease, like those who are immunosuppressed, we can immune restore them. Those who are having the tuberculosis and all, they're more susceptible to the infection. Okay, so, and the infectious agent already I have told. So breaking the chain of transmission is the only goal for the infection prevention and control. Okay, so all champions needs to target this. We need to, day in day out, we need to think about how we can go about it and how we can go ahead for this. We need to have a smart plan for this infection prevention and control plan, that is called as a surveillance, monitoring and auditing. And we need to have an antibiotic policy for it. We need to report all the outbreak, like if certain number of cases are collating in a, or the number of cases are from a single setting in ICU, MRSA, like 5, 6, 7 MRSA back to back nearby courts. So it should alert you that it is an outbreak, and we need to manage this outbreak also. It is also a part of it. And training of all the staff, right from the professionals to your health assistant, whom we call as our Class D staff or the Class-4. So if I talk about the infection prevention and control plan, I quickly will be going through, because I'm showing you something which is taken from NABH guidelines, and it has got a chapter dedicated. So it is one of the guideline which is, talking about, it is one of the guideline which is an accreditation guideline in our country laid down by Quality Council of India. And I'm also assessor for that. So I'm having, access to this, and I am explaining you in their perspective. So entire chapter number 5 is dedicated to infection prevention and control, and how they are, implementing in their settings. So these are all the implementation parts of it, which I'll be talking about in next few minutes. So basically, we need to have a program, and we need to have a program. We need to structure. We need to have a program in a written manner. So you can get the guidance through the guidelines like the IPC guideline 2020, which was released by Government of India, Ministry of Health and Family Welfare. And based on this guideline, we need to write down a manual which is called as a HIC manual. Okay, and it will be based on the organizational priority. So we don't say that you copy paste the manual. Your organization is different. Your organization may be a cancer setting. Your organization may be a smaller setting. Your organization may be having a surgical setting. Okay, so you can prioritize your things accordingly. So we need to have a documented infection prevention and control program in a hospital, and that is in the form of a HIC manual. So what we need to target in the HIC manual? So in the HIC manual, we need to have the high risk activities to be documented. Okay, what are the high risk activities? So if I discuss to you about the high risk areas and the high risk activities, so high risk activities are basically the activities wherein you think that transmission of infection is going to be very, very high. So like aerosol procedures, like any of the anesthetic procedure while they are intubating, it's a high risk procedure, high risk activity. Blood and body fluid spill, surgical procedure. Okay, any of the contaminated medical devices and equipment. So these are having a potential risk of carrying the infection and transmitting the infection. So we need to document them. This guideline at least needs to be reviewed once a year, because we had a guideline in 2020. Government of India can come with the newer guidelines. ICMR can also give, like if you Google ICMR, antibiotic policy, it will be giving you 2023. They have released one policy, 2022 rather, in the month of November or so. They have released a antibiotic policy. So you need to incorporate each and every fact and figures into it, and you need to update it depending upon the newer literature, depending upon your experience in your organization, and then you need to modify it. Okay, so annual review is to identify any of the opportunities for improvement, and then you document it, and you have to document it in the minutes of the infection control meeting. So to do that, there is a validated tool which is given by the CDC. So if you Google ICAF tool or CDC ICAT tool, it will be very well. Or I can share it also to you also. This is a tool which will say you about it is for the baseline study of your own organization. Like if you are working in a hospital, if you it is having the 8 components, and you have to give markings for that. आपके पास infection control nurse है, आपके पास infection control officer है, आपके पास सारे resources हैं. So there are all chapters, and wherever you are lacking, you need to improve on that part. To go ahead and implement this program, we need to have a multidisciplinary infection control committee. So this committee comprises of the administrator, who is the head of the organization, like the medical superintendent, the dean of the college, or if I am from a medical college, CEO, okay, medical director, anyone, if it is a private organization. Microbiologist is very, very important part of it. Physician, intensivist, infection control specialist, please ask them to participate, make them the member. Infection control officer, I am the infection control officer of my organization. Infection control nurses, surgeons, because they will be telling you how, and you have to give them the feedback with the surgical site infection rate, and they will be the person who will be implementing all the care bundle to decrease the surgical site infection rates. Okay, nursing managers. Okay, nurse is very, very important part of this entire almost all the accreditation program, you name it, or you name it infection prevention and control program, nursing is the backbone for that. CSSD is the part and parcel of the infection prevention and control program. OT and ICU staff, please involve them. Support services. So infection prevention and control is not at all a job of a microbiologist and the ICN. It is the job of the entire hospital. Okay, entire hospital. And it is a collaborative approach, and you need to, join hands together to bring down the rate of infection. So laying down the written guidelines and implementation, high risk reduction goals, you have to, lay down, and you have to meet monthly. So this is the laid down guideline by the NABH, but I don't say that you follow it religiously. You can make your own guidelines, but please take care that you are complying with the country's own standard, that is the standard of the country, and this is the country's own standard, that is IPC guidelines laid down by the government of India. Okay, so infection control team we need to have. So whatever I have named, they are all big shots in a hospital, so you cannot ask them to go to the bench and work. So the groundwork will be done by a team which is comprising minimum of the infection control nurse and the officer. I am in my team, I am having the nursing superintendent, also I am having the infection control nurses, the sanitary inspector, also the security personnel, biomedical engineer, because the environmental and engineering controls will be taken care by the biomedical engineer. So they all are part of my infection. CSSD technician is also part of my infection control team. Okay, so day-to-day responsibility of laying down this infection prevention and control program will be in hand of these people. So supporting the surveillance system, detecting the outbreak, okay, doing the audits day to day. So these all are their activities. So designated, I have already told you, designated infection control officer needs to be there. Can be a microbiologist, can be an infection preventionist or infection disease specialist. Okay, ICN is very, very important. You need to designate ICN, and for per 200 bed, the Indian guidelines are there that 200 bed, you need to have a single ICN. But if your hospital is a critical hospital, you can appoint more ICN. To make their job easier, you can also appoint the link nurses. Okay, per 250 bed here they have written, this is a minimum. So link nurses who are already situated in those wards, they can help these ICNs in carrying out their duty. So their main job is to see the isolation precaution, transmission based precaution, infection control bundles are strictly been followed or not, hand hygiene audit. So these are all the things which comes under their responsibilities. So how do you control it in a community? We all have seen the example of the pandemic. I'm not going into the detail. they also need to manage the community outbreaks, both external and internal. So we need to train the staff regarding that. Yeah, infection prevention and control program cannot only work with the men. So wherever we require men to work, we require material for them to make the work success. Okay, so material supply is the job of the administrator, and that's why we have already told that the administration, the management should be the part of the infection prevention, or rather they should be chairman of the infection prevention and control program HICC committee. Okay, so they will be providing the men, HR, as well as the material also. And it is supposed to be needed in a continual and the sustainable manner. It's not like that it's for 1 month and then you withdraw. Okay. We also need to have a allocated fund for this according to our scope of activity and scope of work in our own organization. So what are the adequate things? So the adequate thing, most important of all this, is the provision of the personal protective equipment. Okay, so gloves, mask, apron, gown, boot, shoe cover, cap, hair protective eye gear. So these all we have already seen how to use the PPE, how to remove the PPE, donning and doffing. We all are well versed with the huge experience of the COVID-19 pandemic with all three waves. It also need to have an adequate facility for the hand hygiene. And if I talk about the hand hygiene, it is not only the facility, rather you should have a hands-free tap, a soap, a large wash basin, and none other than the water supply. Okay, continuous wash basin hai, hand soap bhi hai, liquid soap, but water nahi hai. So is there any point? No. Hand rub facility in the area where you cannot do the hand wash. So in ICUs, we definitely say in the critical areas like the ICU, you need to use the hand rub from one patient to another to prevent the transmission of infection. Okay. So one very important, so these are all the standard precautions. So very important is the additional precaution, that is the isolation and the barrier nursing. So when we need to have a barrier nursing, when we suspect that patient is able to transmit the infection to the community, so we put them in a negative pressure room and with the appropriate signages, and it's always closed, and whosoever goes, protect himself or herself with entire barrier, and this barrier is the personal protective equipment. Okay, so entire PPE you need to. So for the swine flu cases and for like H1N1 cases, and also for the COVID, also for very important disease in India, and we are targeting to make India tuberculosis free. So tuberculosis is such an infection which is spreading very rampantly and through the airborne. So there also we need to have the bed distance should be appropriate. So with the coughing, it is not transmitted from one patient. So these are all infection prevention and control tools and guidelines strategies. Okay. So adhere to the standard precaution in all the areas of the organization and all the times. Okay, so standard precaution is nothing. It will start with the hand hygiene and adhere to that international guidelines. So today is the hand hygiene day, World Hand Hygiene Day, and how. So when to wash your hand and how to wash your hand. These two things, if it is clear to you, you will be able to achieve, I already told you, 60% of your goal. So, whenever you are supposed to touch a patient, before touching a patient, you need to wash your hands with the 7-step WHO hand hygiene steps. Before doing any of the clean aseptic procedure, like doing a surgery, doing a pleural tapping, peritoneal tap, any damn thing, doing a dressing also. Okay. After touching, after blood and body fluid exposure, like if you are, decanting the Euro bag and got a spill in your hand. So after that, by default, you have to wash your hands. After touching a patient, also you have to wash your hands, and after touching the patient surroundings. So all the fomites, bed, they are all, articles nearby. So you have to bed rail, bed pan, anything you touch, you need to wash your hand, patient surrounding. Okay. Their locker, anything. So what are the types of hand hygiene? So if I talk about the hand hygiene, I should never forget about the types of the hand hygiene. And one of the important type is whatever we do when we go to a meeting and followed by a lunch, we do a hand hygiene which is called as a social hand wash. Okay, social hand hygiene. Whatever we do inside a hospital setting, it is a hygienic hand wash. It can be done with the soap water, it can be done with the hand rub. And whatever we do in a critical environment like the operation theater, it is a surgical hand scrub. So there one more step is added, and you need to be more, careful about it. Till elbow you have to scrub everything and wash your hand, don't touch anywhere, and go and do the surgery. Okay, so these are all 7 steps of hand washing. I'm not going into the details. Probably today, after entire sessions, both the sessions are finished, you can all have a hand washing session or hand hygiene, the steps of hand hygiene, so that this is the only tool which is free of cost, cheapest of the tool which is available to prevent the infection. Okay, so there are all 7 steps of infection, and anywhere if you touch anything else and you change the sequence, okay, it is so hand to hand, it is palm to palm, then it is over the dorsum to palm, it is finger interlaced, then opposing the palm, that is a knuckle, then your thumb and all your tips of the finger and your wrist also. Okay, and then you have to dry, that is very very important. If you keep on using the towel which is used by the other, the towel itself is a wet and it will transmit the infection. Okay, with the hand rub also we need to do the same practices. So whenever you do this, you have to speak 1 2 3 4 5, 1 2 3 4 5, 1 2 3 4 5, or 1 2 3 4, even 10 counts also you can do, 5 counts also you can do, but you need to see 10 counts you need to do for the hand wash, and 5 counts you need to do for the hand rub. So these are the actual steps. Okay, this is the surgical hand scrub, and these are all touch free, hands free surgical scrub stations, and see how they're scrubbing, how they're scrubbing before going into the operation theaters. Okay, so we need to also adhere to the transmission based precaution. I have already told you about it. Transmission based precaution, that is a negative pressure ventilation room, isolation rooms and all, and also transmission from the purulent material one to another. You can use the gloves also as part of it. Infection prevention and control talk about the safe eye practices, that is a safe injection and infusion practices, and it needs to be adhere religiously all the time, and the mantra is 1 needle 1 syringe only 1 time. Okay, so we are not expected to reuse the needle. Those days are gone, and please don't remember it. Gujarat has faced a very deadly outbreak in the Modasa of the hepatitis B because of the reuse of the needle by the quack in year 2008. Antimicrobial usage policy. So once you establish this program, you need to talk to your microbiologist to show you how many samples they are sending, and so this is little detail, I'm not going into it. Once your program is set up, down the line you will be developing antibiotic policy. You can definitely refer to the ICMR guideline for this. Okay, and also with the antibiotic usage policy, there is very very important thing, that is there is a national treatment guideline released by the ICMR, and also you need to have a list of the antibiotics which are reserve antibiotic, and we say it as a restricted antibiotic which cannot be utilized just like that. Okay, like colistin, vancomycin, imipenem. So there is some control over use of this antibiotic, because there is a fancy global problem which is happening, that is a rampant spread of the antimicrobial resistant organisms. So antimicrobial usage we need to monitor, and here it is telling about the ordering of the restricted antibiotic and as per the organizational policies. Okay, so stewardship program, it is next step ahead. Engineering controls. So I talked about the biomedical engineer. I also talked about to you about the OT settings and also about the negative pressure rooms. So what are they? They are all the settings which is designed by the hospital engineers. Okay, so they are all hospital engineering settings wherein we need to have a air handling unit, or AHUs. We call them as the AHU. So these units are such that a clean and filtered air is released into that particular closed environment. Okay, so if we talk about, so air quality check of the AC plant, the equipment, AC duct. AC plant happens to be, because there is a lot of moisture, it happens to be one of the important source of the fungus and other aerosol borne infection. Okay, AC duct and filter needs to be cleaned, replacement, and prevention of the fungal colonization. Water testing is also a part of it. So water quality testing, definitely you can refer to the NABH guideline for the OT air conditioning. It is also already there in the NABH site. And the testing of the water quality monthly by the microbiology lab for the coliform count, and also the water quality testing quarterly for the chemical testing. Okay. So in the construction and renovation, we need to have an infection prevention and control checklist so that you know how much risk of infection transmission is there with this renovation work. Because when we break down the things, break down the bricks and all, there are all chances of the fungal colonization. Okay, housekeeping needs to. So when I talked about the sterilization and disinfection practices, so all the housekeeping staff needs to be trained about it, and housekeeping staff need to know what are their critical areas, semi-critical and the non-critical area, and how many times they need to clean it. And a hospital approved disinfectant solution you need to give them so that they can use the daily cleaning of all these area with these hospital approved disinfectant solution. Okay, so they should adhere to it. Biomedical waste management is also a part of it. I'm not going into the detail. Yesterday we have, you can have a team, you can have an infection control team, you can have a biomedical waste management committee, you can have any blah blah things, but implementation part is more important than having a committee. Linen and laundry are also a part of infection prevention and control. So handling a soiled linen. Yesterday I talked a little about the pre-treatment of the linen, so I'm not going into the detail of it. Okay, so linen and laundry, and mind well that whatever the infection, whatever the things which comes under the infection prevention and control practices, which are outsourced, like biomedical waste management outsourced CBWTF, that is a common biomedical waste treatment facility. The linen, if you have outsourced, okay, the laundry, if you have outsourced, we need to visit it in a 6 monthly basis so that you know that they are also following the standard guidelines. You need to take the photographs, you need to train them, you need to see how they are working. Food, it is one of the important source of infection, and food outbreak are very difficult to tackle. And n number of diarrhea cases you will be having in your hospital setting. So if your food services are outsourced, go and see how the dietary services are maintaining it. If it is in house, you need to check regularly their cold storage, their dry storage, their distribution of food, their trolleys, the protective gears of all the healthcare professionals, those who are serving the food. This all needs to be done. Refrigeration condition of the food handling, and also you need to check whether these staff are screened for, they are vaccinated for typhoid and hepatitis A, and they are screened for the salmonella and the cyst or ova and cyst, that is the parasites. Okay, so these are the four, how to prevent the catheter associated. I'm not going into the details because I think next session is about HAI only. So catheter associated urinary tract infection, adhere to the standard precaution and the care bundle made for it. Ventilator associated pneumonia, adhere to it, and you need to adhere to its care bundles also. So catheter associated bloodstream infection, same way. So these are all CDC defined criteria, and these four diseases like catheter associated. So how CDC has defined it? It is a procedure associated and device associated, and it is said that device is the attributable risk factor. So if you think that the patient is not in any device, they are at a lower risk than if a patient is in catheter or ventilator or central line. Okay, so one is a device associated and second is the procedure associated, that is a surgical site infection. So we need to have a pre-op, intra-op and the post-op care bundles defined for it. Okay. And then you need to calculate the rates. Okay, and then you need to analyze this rate and give the feedback to the clinician and consultant depending upon the trends and rate, that how we can, what are the uh, what are the basically strategic plans. Okay, the kappa, what we say, the corrective and preventive actions to prevent and bring down the rates. Okay, so data needs to be verified. So the data cannot be made in, like, if I'm sitting in my cabin, I cannot prepare the infection control, prevention and control data. It should match with your raw data. Like if अगर एक patient को SSI हुआ है, तो it should track back to that particular patient. So it cannot be just like that कि मेरे को आज अच्छा लगा 5% कर दिया, कल 5 का 2% कर दिया, not like that. It one-to-one verification and validation of the data is also needed. So it is surveillance is identified towards the high risk activity also as per the national and international guidelines, and we need to monitor the hand hygiene compliance also. So WHO has given, if you Google WHO hand hygiene compliance form is there. I will be giving you the entire bundle of the things once I am free, and I'll be sharing it to Ruchika ma'am or sir also. I can share in the RC Bhubaneswar that mail ID and monitor it every month. So once I told you this is the simplest of the tool, and this is one of the cheapest of the tool, hand hygiene, to prevent the infection. But we need to see how religiously we are adhering to it. So to your surprise, when we conduct this audit, the doctors are the most difficult persons to do it. Okay, and the class 4 staff, those they, because they keep on changing, the nursing staff very well adhere to it. So we need to monitor this multi-drug resistant organism. We also need to monitor the effectiveness of housekeeping practices. We need to give feedback to our own clinician, so that what are the trends and how much they can, how they can implement it, and how, rather, how they can put the effective measures to control it. Okay, and the how then comes the identification of the outbreaks. So early identification of the outbreak is very very important. Define the outbreak as per the WHO definition criteria and handle the outbreak as per the guidelines. Okay, and hospital infection control committee analyze all the data and take the corrective and preventive action, and they do the prevention to recurrence of this infection. Okay, there is very important part of the infection prevention and control program or a hospital infection, and that area is called as a CSSD, Central Supply Department. So for many of you, it is only a single autoclave, but mind well, it is not only the autoclave which is a part of the CSSD. It is entire cleaning of the instrument, disinfection of the instrument, drying of the instrument, packaging of the instrument, and then putting it into the sterilization process, that is a sterilization area, storing it in such a way that it is not mixed with the used and unused one, and then issuing it in a unidirectional flow. Okay, so this is one sterilization activity, because we all know that if you don't sterilize, you might have heard about the atypical mycobacteria after post-operative infection after the laparoscopic surgeries. You might have heard, and it takes 1.5 or 2 months to grow. Okay, atypical mycobacteria will grow very fast, but the infection will occur in a period of 1.5. So, for the surgical site infection, even the patient is discharged, our job is not over. We need to follow them up. Okay, once they come back and follow up, we need to call them, ask them, and all. So these are all. Cleaning helps to remove the visible microorganisms, including the spores also. So sterilization is the process wherein we render them free from all the microorganisms. This is the Spalding classification. So anything which you think is going to be used in a OT, critical area, is going to breach the continuation of the skin, please sterilize it. Don't even depend on the high level of disinfection. Okay, nowadays plasma sterilization, this gamma sterilization, plasma sterilization, ETO sterilization, all is available. Anything which is in the skin and mucosa, you can use, like stethoscope, you can clear it, it's a non-critical. BP cuff and all, they are non-critical. You can, with the low level, even with the alcohol rub, you can clean them. Okay, so cleaning, packaging, disinfection, I have already told you about the CSSD as per the written guidance. And if you are reprocessing, you need to have a reprocessing guidelines. Also regular validation. So, you cannot run an autoclave without a physical chemical indicator daily, using the strips and the biological indicator at least weekly. Engineering validation, like the leak test and the Bovidic tape test, needs to be done, and each load should have a unique number. If the load fails, we need to recall them. Okay. So breakdown in the sterilization system, that should have a batch processing system and have a recall mechanism effectively in place. Okay, and for the occupational safety, occupational health, we need to reduce the risk of transmission among the. So a healthy, it is said that a healthy human resource will be with you for a longer period of time, and will be, with all mind and physique will be serving to the hospital and the patient. Okay, so provide adequate resource. Standard precaution should be provided to them. Their pre-employment screening is supposed to be done annually, and immunization also should have to be maintained. Hepatitis B as well as the tetanus toxoid vaccination is recommended, and all other like COVID-19 nowadays it should be part of your immunization policy. Okay, and transmission precaution restriction, like if anyone is having a coryza or anyone is having the cough cold, so they should not be sent to the areas where there are so many number of the patient being posted. They can be given some administrative work like acute respiratory infection, tuberculosis, conjunctivitis, and chicken pox. But don't penalize them. Just ask them so that you come with the right answer, and they are not in a they are rather they are basically they are open enough to say all these facts. Okay, so it should not be like that they are under the threat that they are not speaking the truth. Appropriate personal protective equipment needs to be there for blood and body fluid, and post exposure prophylaxis definitely as per the NACO guideline for hepatitis B, hepatitis HIV, and hepatitis B also. So the entire mantra is break the chain of transmission, which I showed you earlier in my picture. And today is the Global Hand Hygiene Day. So let's pledge that we will wash the hand, or for all 5 moments of the hand hygiene, for 5 moments which are needed for the hand hygiene, and we will never ever forget it. So thank you so much, and I'm done with my session. Hello, hello, yes sir. Hello sir.
Yes,
Yeah,
yes, yes.
Gagandeep Kaur has raised her hand.
Yeah, ma'am. Ma'am, I raised my hand that when you were talking about checking of the water, so
Hmm.
all water have to be checked, the hand washing water, the drinking water, and the water supplied everywhere.
Yeah,
Not
so
just,
the point, yeah, let me clarify it. So all the critical area, so drinking water definitely, क्योंकि आपको पोटेबल वाटर देना है, और पोटेबल वाटर जो है वो कॉलीफॉर्म से इन्फेक्टेड नहीं होना चाहिए, तो ड्रिंकिंग वाटर। सो आपको स्ट्रेटेजिकली अपने एरिया में जहां जहां आप वाटर टैंक्स लगे हुए हैं सारे टैंक्स में से टेस्टिंग करनी होती है, और जहां भी उसका आउटलेट आ रहा होता है आप उसको स्केड्यूल कर सकते हैं, और उसके बाद आप उसकी टेस्टिंग कर सकते हैं। ओटी वाटर डेफिनेटली, एंड
okay,
सीएसएसडी
thanks,
आल्सो।
ma'am. Ma'am, what? Yeah, thank you, ma'am.
Any other question from anybody?
Yeah, Shashank Shekhar Panditra has
Yes,
raised
ma'am.
a hand.
Good afternoon.
Yeah, very
Ma'am,
good
I just
afternoon.
want to know, in our hospital, we have used bacillocid extra for mopping of the OT's area,
Okay.
but it's cost a lot. So after daily use, we can use the bleaching, like hypochlorite solutions for mopping, or any other things that can be used.
Yeah, mopping of the areas, mopping you can do with a phenolic disinfectant also. But in the OT area, I will definitely say that you should use something which is having the hydrogen peroxide and silver nitrate type of the mixture, because this is not a very effective in the critical area. So you can, in the critical area, basically not the floor mopping,
Okay, ma'am.
but the surface, your racks, your instruments, these all needs to be mopped by the bacillocid,
Ma'am,
so you can schedule that.
okay, ma'am. Okay, ma'am. But so it's not necessary to mop the whole OT corridors also with the
No,
bacillocid.
no, 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 no. OT corridors and all you can mop with this phenol and all disinfectant.
Okay, okay.
Bacillocid mopping is only recommended for the disinfection of the surface.
Yes, ma'am. Yes, ma'am. Okay, okay. Thank you, ma'am. Thanks a lot for it.
Any more? Yeah, Joby Viju has raised a hand. Biju, yeah, you have raised your hand, but you have become disconnected also. મોહિત હું લેક્ચરમાં છું, પછી કોલ કરું. Anyone else? Because there is a team from the CDC has come to my organization and
Prabhat Kumar, please ask your question.
Good afternoon,
Sir,
ma'am.
Yeah, very good afternoon, please.
Ma'am, you have told the OT there should be positive pressure maintenance, and in some areas negative pressure maintenance. But how it is being done?
मैडम मैं 2 मिनट में आऊँ, 2 ही मिनट लगेगा. हाँ. See, positive pressure ventilation, it is a hospital engineering part. So entire positive pressure HEPA filter all needs to be installed. Super specialty OT, it is recommended to have a positive pressure ventilation. So this is a hospital engineering part wherein you have to involve all your, hospital engineers also into it, and the biomedical engineer, you have to get it installed. Okay. So this is altogether a different entity, and it needs to be there inside the OT so that you are getting the filtered. So this is now a newer concept of the modular OT wherein these all HEPA filters are there.
Okay, ma'am.
Yeah, Biju, please ask your question. You have raised a hand.
Biju, please ask your question.
Sir, can we go ahead quickly with this question answer session, because a team of CDC has come to my organization and I have to attend them.
Okay, no problem. So if there is no other question from the side of the student,
or ask them to mail it to you, immediately you will be answering into that. Will that be fine, sir?
Yes. If there is any other question, please mail to IGNOU Regional Center Bhubaneswar, so that the same will be forwarded to madam, and you will get the right reply. So with this, we conclude the present session. So at 4 o'clock today, we have another session, and I request all of you to please stay back. And I, on behalf of School of Health Sciences and on behalf of all the staff members of Regional Center Bhubaneswar, I extend my hearty thanks to Madam Soni, and because she took 2 sessions, yesterday also and today also, so beautifully. So I think the presentations made by Dr. Soni must have been very much helpful to all of you. So we shall be having similar kind of sessions in future also, and we'll be inviting Madam once again. Madam, thank you very much.
Okay, thank you very much, and I hope I am able to clarify the topic also. And if any queries, please do write email to RC Bhubaneswar and they can forward it to me, so that with all confusions, you should never go back home. Thank you so much. So I am, sir, leaving the session.
Yes, madam. You can go now. Okay, thank you very much.
Thank you.
So students, please stay back, because there is another session. Madam has already arrived. Madam Lalita has already arrived. Madam, are you there?
Yes, sir. I'm just joining. 2 minutes.
Okay, madam. Please carry on.
Good evening. Let me share my PPT.
Okay. So, dear students, as informed to you, now it is the second session of the third day,
Yes, sir.
and it is based on hospital acquired infections.
Yeah.
And this particular topic will be, you know, Dr. Lalita will be talking to you about this particular topic, and we are very much thankful to Dr. Lalita. And you must be knowing, because he has already taken a session on 3rd May, and you all must be knowing that Dr. Lalita is the professor in community medicine in Ramaya College, and we're really fortunate that we got an opportunity to listen to her. So please be attentive in the lecture, so that you can benefit from the presentations made by Dr. Lalita. So, madam, please, you're welcome, and please take your session. Thank you.
Thank you, sir. Hope the slides are visible.
Yes, ma'am.
Yeah.
Yeah.
Yes.
Okay. I think it's a continuation of what Sony madam has already spoken to you all. Uh, I'll just close my video so that I can easily navigate the pictures. Okay, today we'll be discussing on hospital-acquired infections, also called as nosocomial infections. What do we understand by this nosocomial infection? This is an infection acquired by the patient while in the hospital, either during the hospitalization or after his or our discharge. So, if you look at the definition, this is the definition by CDC, which is defines HAIs localized or systemic condition resulting from an adverse reaction to the presence of an infectious agent or toxin without any evidence of it being present or in incubation at the time of admission. That means to say that the patient who was admitted didn't have any of this infection, or he didn't have any infection in the incubation period. So whatever infection he's got, it is got within the when he's while he's only because he's come to the hospital he's got this infection. Okay, so this is usually referred to as any infection which occurs on 3rd calendar day. That means technically for operational reasons we say any infection or fever which is occurring after 48 hours after the admission time is referred to as hospital acquired infections. This is why this 48 hours. This is basically the kind of infections what we usually term as hospital acquired infections are usually the incubation period ranges between 24 to 48 hours. So more than 48 hours, it's unlikely, and we can easily recognize. So within 48 hours, if any infection is there, probably the patient had the infection earlier. Only when he has come to the hospital, it has manifested. So any infection occurring or any fever which is occurring after 48 hours is usually termed as hospital acquired infections. So this means it includes even of the infections appearing after discharge, means that the patient is admitted to our hospital, and even after going back at home he develops fever after 1 or 2 days, means that is also because of probably infection which has occurred within the hospital. And any occupational infection occurring among healthcare workers also usually referred to as nosocomial infection. However, it does not include colonization, that is a local wound which is getting infected, or inflammation resulting from tissue response to injury or non-infectious agents like your chemical burns, or some accident has happened after that inflammation has occurred. That does not qualified as hospital acquired infections. Now, why HAI is important? One, prevalence is almost, it says it's about 9%. It increases the morbidity and mortality of the patient, chances of them increasing, right? And it complicates the severity of illness the patient has come with. The patient probably has come with some infection. Because of hospital acquired infections, his condition has become much more severe, and which may result in prolonged length of stay in the hospital, or sometimes it can even result in death. So what are the consequences? It can cause economic consequences to the patients and families, to the hospital as well, because you are going to block the beds for those people, and for the community and the country it is going to be an economic loss. And what again further what may happen because of these infections which are hospital acquired, hospital infections, what are there, they are already exposed to various antibiotics, so the chances of them being antimicrobial resistance is very high, so the risk is more, so you may have to use higher level of antibiotics as well. And for healthcare workers, the risk of HIV and hepatitis B and C is always there. So we should know that we are hospitals are there to cure infections, and we should not give infections due to improper infection control and management. So what are the factors which will affect hospital acquired infections? So one is immune status. The patients, because of their immune status, they're easily vulnerable. Otherwise, probably they wouldn't have got this infection. Because of their immune status, they are easily contracting this disease. May I ask, is the slide changing with my flow of talk?
No, ma'am. Only one slide is visible at the top.
Oh, is it? Oh, I'm sorry about it. That's why I wanted to know. Uh, I mean, the factors affecting hospital acquired infection that is seen, right?
Yes,
Yes,
ma'am.
madam.
Yeah. Okay. Next is the hospital environment. Basically, the environment of the hospital, what organisms it's lodging, which can enter the patients. Okay. And what are the diagnostic and therapeutic interventions we do? Example for surgery, for that matter, open surgeries are at higher risk of people getting infections. And transfusions, this also predisposed to HI. And poor hospital administration. We are not having good practices or hygienic practices, or there is no policies and bundle care or of those kind of things that will predispose to hospital acquired infections. Is the next slide visible?
No, ma'am.
No? Can you read the slide for me? What slide you are seeing?
Factor affecting
Factors
HA.
affecting HA.
Next slide is not gone. Major types of hospital acquired infection.
No, ma'am.
No, ma'am.
No, ma'am.
Okay, I'll skip it.
It has come now.
It's come now. Maybe it's slow a bit. Okay. So basically, there are four important hospital acquired infections which we concentrate as part of our infection control practices. One is the catheter associated urinary tract infection, that is usually referred to as COTI. Central line associated bloodstream infection, which is called as CLABSI, and VAP, that is the ventilator associated pneumonia, and last one is the surgical site infections. So these are the major types of hospital acquired infections which we commonly do under surveillance as well. Now, coming to the what are the agents which can get in? It could be ranging from anything from bacteria, viral to fungal and parasitic. And where do we get these sources of infection? One, we, excuse me, it could be endogenous source or exogenous source. Endogenous source means patient's own flora. For example, if you are doing a surgical incision, the patient's own flora can be a predisposing factor and they can enter. Second, exogenous source, that is outside the patient environment, that is the outside environment or the healthcare workers, that is it could be doctors, nurses, waste handlers, whoever it is, and also other patients also can transmit the infection. So these are some of the sources of hospital acquired infection. So it could be a case or a carrier. It could be a clear case of tuberculosis from a next patient also you can get, or it could be a carrier whom you do not know is not manifested because of his carrier state. For example, you have known this typhoid carrier who served the food for a long period, got typhoid Mary, who spread the case diseases for a long time. So similarly, a patient attendant to could be nursing faculty or the food suppliers. If they are carriers, they can also spread the infection. Secondly, improperly sterilized instrument and dressings. These can, which have infections, can easily transmitted. And all your fomites, that is the instruments, bed sheets, all those things can be your source of infection. Next is the vehicle, which are easily transmitting all of your blood and viral pathogens. That is your food, water, milk, blood, and blood products. That's where your transfusion can be an important source of hospital acquired infections. So, how do we get inside? How does that get into our body? One, it could be on the skin. So, when you do this incision or some procedure, it can get inside, or it could be in the air we breathe in, or endogenous flora, or contaminated equipment of the hospital and environment of patient, like your bedpan. Simple bedpan can be a source of this thing, or your bed sheets. Okay, an important thing is our hands of healthcare professional. That's why Sony ma'am was mentioning about your hand hygiene, which is very important. I think hand hygiene is one of the important and the simplest and the scientifically sound measure of reducing the hospital acquired infection. And second, lastly, water we what we drink or what we use for cleaning or whatever purpose, it should be free from pathogens. Now, who are the people who are susceptible for hospital acquired infection? Majorly, it is the patients because of their immune status. The other group could be our healthcare personnel itself, that is the medical doctors, nurses, healthcare auxiliaries, and hospital maintenance personnel. Also, the visitors who are visiting to attend the patient can be the susceptible group. And importantly, we have these workers who are handling this waste. Yesterday's class, I had mentioned waste handlers, because they do not know the severity. They may be neglecting in taking necessary personal protective equipments or precautions, which can lead in transmission of the infections such as HIV, hepatitis. Similarly, rat pickers who are completely ignorant and unaware of the seriousness of the hazards of the waste, they are also very susceptible for these kind of hospital acquired infections. Unfortunately, we focus on mostly the HAI of patients, but the infections which occurs amongst the other group, very rarely we attribute to the hospital acquired, and we really fail to attribute to the hospital source, and we may miss the real incidence or the prevalence of hospital acquired infection. Therefore, whatever HAI we report, we usually concentrate on the patient's data as such. We do not really document and report of other categories. So, how does the transmission occur? As I was telling, it is basically from the endogenous or exogenous source, and the route of transmission is varies. Similar to any infections, how it can be, we have contact infections and droplet infections, airborne, vectors, and needle stick injuries. Let us touch each of them a little bit. In contact, also we have two groups. One is the direct and the indirect. Direct, like your blood transfusion, can directly transmit your HIV, hepatitis B, C. Similarly, by touch, you can get staphylococcal, viral hemorrhagic infections. Again, indirectly, not direct onto the body, it can from the eating, or if your hands are not clean enough, you can get your staphylococcal infections, viral hemorrhagic infection, and Clostridium difficile. And instruments, if it's not properly sterilized, hepatitis B, HIV, tetanus, pseudomonas, such infections. And food contamination, indirect way of getting inside, you can get diarrhea due to salmonella and typhoid, like that. And similarly, water also contamination, you can land up in cholera, shigella, and dysentery. So these are some of the contact mode of transmission. Similarly, we have droplet and airborne infection. I'll come to it little later. And vectors, of course, if you do not take measures of having vector control measures within, say, in and around the surrounding of the hospitals, you can definitely have mosquitoes, and your wards are not meshed and do not have a mosquito mesh thing, you can land up in fever, malaria, yellow fever, and dengue. And needle stick injuries, we all know HIV, hepatitis B, and C can be transmitted, whether it can happen accidentally or by oversight. So these are the different modes of transmission. So contact transmission, we, as I told, it's basically contact is direct skin to skin contact the organism gets in. Like contaminated indirect Inanimate objects also can transmit. For example, simple your stethoscope, it is not frequently cleaned, that can also spread indirectly the transmission. And parental transmission through needle stick injuries, blood splashes, saline flush, syringes, and vials also can be source of infection. Now coming to this droplet, and we always have this confusion: what is this droplet infection and what is this airborne infection? Droplet infection refers to any infection which is occurring because of a droplet which is more than 5 microns. These more than 5 micron size can travel only for a shorter distance because they are quite bigger and heavier. They do not travel longer distance. So usually they fall within the 3 feet distance, and this usually happens when they are coughing, sneezing, or talking, because it's short directly. It can land up in the land up on the post, and they can get the disease. Like your simple examples are RSV, diphtheria, bacterial meningitis. Airborne transmission is because of droplet nuclei, which is much more smaller. That is, your less than 5 microns. That your Mycobacterium tuberculosis, measles, varicella, legionella. These are the organisms which are on they are in the suspended in the air for a longer time, and they can travel longer distance also. So these are the different types. You understand the difference between droplet and airborne? Droplet is usually bigger, that is more than 5 microns, and they travel shorter distance because they are quite big. And similarly, a droplet nuclei, which is less than 5 microns, are suspended in air and they can travel longer distance. Vectors is because of mosquitoes, flies which carry the organisms. This is quite rare, but it can occur if there is food and water contamination, and they can get in. Now, what are the links in chain of transmission? So, like in any infectious agent, infection transmission, we need to have an infectious agent, a reservoir from where a reservoir or source from where the infectious agent starts, portal of exit from where it comes out, and from where it transmits, modes of transmission, and finally how it enters the body into the susceptible host. So this is about general links of transmission. So when we are looking at prevention of hospital acquired infection also, we must keep in mind all these chains, which is important to prevent our this thing. So any break in this chain, I think madam has told about your agent, host, environment, all this chain is very important, and we have the mode of transmission which will keep a link of this. So we must see how we protect our host, and we must see how the infectious agents do not enter the host. Am I fast, or is this speed okay?
Okay, ma'am.
Okay. Thank you. Now let's look at prevention of hospital acquired infection. Broadly, we can categorize this into two standard measures. That is the standard precautions. The second is the transmission based or specific precautions. What is standard precautions? Like, I think we were using the word universal precautions. That is now replaced by standard precautions. Universal precautions, what we understood is it's applied to blood and body fluids containing visible blood for all patients. Basically, we were assuming that any blood and body fluid containing materials, probably HIV, and would take all the precautions. Similarly, we have now replaced this, it's called as standard precautions. This refers to applying the principle of work practice controls and exposure controls to all the patients and all the specimens. It's not necessarily only to the patients, to all the patient specimens also, to see that you prevent exposure to the workers, to the potential infectious agent, and also patients as well. So these are the set of infection control practices which are used to prevent transmission of disease through any mode of contact. It could be either due to blood, body fluid, or non-intact skin or mucous membrane. So it is basically to prevent, minimize the transmission of hospital-acquired infections. What are the things we need to look at when providing care to handling all individuals? This applies to when we are handling patients or as an individual, or to all specimens also. Even if you're in a laboratory setup, the way you handle your blood or body fluids or samples, you must be careful and applies the standard precautions, and also while handling your needles and sharps. So this is where you will apply standard precautions to the individuals, to the specimens, and to the needles and sharps. So we have different standard precautions which we need to apply, which is important to prevent hospital acquired infections. One of the most important one is hand hygiene, which madam has already very detailedly discussed with you. Hand hygiene. Next is the use of PPE and management of needle stick injuries, environmental cleaning and disinfection, patient care equipment cleaning and disinfection, linen management, standard precautions while handling the linen, safe injection practices, respiratory hygiene, and safe waste disposal. All these standard precautions must be applied in all of these aspects. Then is when you can reduce your hospital acquired infections. Now let's look at the hand washing. I think madam has very told up. Just to recap the thing, because it's very important, I want to reinforce that it is very important. Basically we have different hand washing techniques. I think social hand washing, this is what we do at home before eating food, or as a ritual we do it, right, as we come back. So careful hand washing, sometimes after cleaning the patient contact we wash the thing. Hygienic and disinfection, this is after disinfection are occurring after decontamination. Surgical and disinfection, this is a pre-operative disinfection. So these are the main purpose of different hand washings: social hand washing, careful hand washing, hygienic hand washing, disinfection, and surgical hand disinfection. So, what is the purpose? I have told you. How you can do agent of action for social hand washing? Simple soap will do, non-medicated soap for social and careful hand washing. But for hygienic disinfection, you need to use alcohol-based disinfectant. And for surgical disinfection, it should be antibacterial soap and alcoholic solution. So rapidity of effect will be social and careful will be slow, whereas hygienic disinfection will be very fast. The hand rub, whatever you do, and if rapidity effect in surgical hand washing will be slow with soap, fast with alcohol. Residual effect, except for surgical and disinfection, that is residual effect means the effect of being disinfected when clean will be for longer time in surgical disinfection. In the rest all it is short period. So it is just that momentary. You need to repeat your hand washing if you touch something else or do something else. So I think the 5 moments for hand hygiene. Can anyone tell this? Because madam has already discussed. Just to see if you're all still awake in this post lunch session.
Yeah.
What are the 5 moments?
Before
Yes.
any procedure, after any procedure, before touching the patient, after touching the patient, and touching the patient's surrounding things.
Very good. So very good. So before touching a patient, before any procedure, and then after body fluid exposed parts, and after touching a patient, and after touching patient surroundings. So these 5 moments we must remember. And in fact, some places nowadays, what do they do is, in fact, every ICU beds they do have a hand rubs and washing facility so that they do it properly. When do you do hand rub and when do we do hand hygiene? What is the difference between these two?
Hand rub we
Anybody?
can hand rub we can do through. In COVID we are using hand rub by on the hand hygiene for any procedure.
Yeah. Simple is for us to remember is, and rub is done with your alcohol based formulations. And wash has to be done with soap and water. Whenever there is visible dirtiness, that time we must do hand wash. Not hand rub will not be suffice. If visibly our hands are not clean, we must do hand wash, and then only probably you can add on with your hand rub. So I think hand rubbing and hand washing, we all know about the 10 steps of hand washing. Same, either hand rub or hand hygiene, we must follow all these 10 steps. We will probably at the end, we will conclude with this hand hygiene sessions. Next, coming to the personal protective. So hand hygiene, after hand hygiene, I think is one of the thing, simple procedure, but I feel it is one of the scientifically sound intervention which we all need to diligently practice and also monitor. See to that all doctors, nurses, and waste handlers follow this very ritually. Now, next is the personal protective equipments. I think we are all very familiar with the PPE, with the COVID. It has underlined our importance of using this PPE, and we must know when to use what. For example, gloves, non-sterile gloves can be used when there is risk of infection to healthcare workers, like just while handling your blood, body fluid secretion, basically to protect yourself. When you are handling the surgeries or invasive procedures, in order to prevent infections to both the healthcare workers as well as patient, you can use the sterile gloves. Okay, and plastic apron is usually used during surgeries. Gown also during surgeries, especially when there is likely that there is going to be soiling either due to blood or body fluids, especially during labor or any surgical procedures. Again, mask also, I think we have got enough information now. N95 mask is whenever there is airborne precautions, now even in COVID cases also, whenever we are expecting there is lot of procedures which we are going to do, like during intubation or in ICU, we need to know N95. Otherwise your triple layer mask is good enough for the droplet precautions. And cap, face shield, goggles should be used, especially when we are handling the cardiac surgeries or when you're doing any airborne interventions, whatever you're doing. And shoes in OTs and ICUs is mandatory for preventing infection entry to the environment and the patients. So these are different personal protective equipments. So the choice of PPE should depend on the level of risk associated. So whether you are going to get contaminated with skin, mucous membrane, or clothing, depending on that you must decide. And also the route of transmission. What could be the route of transmission of that organism which you are likely to come across, whether it's contact, droplet, or inhalation. Based on that, you have to choose your PPE. And I think it is donning and doffing. All of us have known what is the steps we have to do, and the donning will be done in one step, and similarly the reverse of it will be the doffing with a mask removed last. Next important is for safe injection practices, because giving injection, one, you must also see to that the patient is getting right injection and without getting any infection. Similarly, during the process of injection, we should ensure that we do not land up with needle stick injuries. So for safe disposal of sharps, what are the do's you must follow? Handle needles and syringes minimally after use and use extreme care. Dispose your hypodermic needle scalpel blade is in the puncture proof containers. That is as mentioned in our rules also. Tamper proof, puncture proof, leak proof container immediately, and it should be very close to your place of injection. So if you are giving injection near the bed, your white container should not be somewhere in the corner of the hospital. Okay, you should be able to have one container close to your dressing table itself. Okay, any delay in disposal of sharp will increase the risk of occurrence of accident. So as I told, puncture resistant container should be conveniently located as close to as possible, and using medication vials for one patient only whenever possible. And don't, for safe disposal, do not recap. If you have to recap, what method we can use? We can use what is called a scooping technique, wherein you keep the cap on the table, and like scooping, you put the needle into the cap and then lift it and then close the cap. You should never ever directly keep your hand, what is a cap and syringe in one hand and try to recap, because its risk chances of needle stick injury is very high. And do not bend or break the needles after use. Not required. We do not, before we used to say break, bend, because that is the time you may injure yourself, so we do not recommend that. And do not reuse the same syringe to give injections to multiple, even if the needle is changed. This is what they say. But now, as I was telling yesterday about regarding plastic reduction and all, there are things which we may have to look at. And never leave one needle. This was the thing, I think before we used to see one needle in one vial and multiple injections we used to do, because there is chances of contamination and repeated infections which can cause between the patients. So to be needle smart, do not recap, do not bend, do not remove, do not transport open-ended, and do not reuse as much as possible. So that is where our one needle, one syringe, only one time has come into concept, which has other reasons. And for single-use needle syringes, what we are supposed to do, dispose the needle without bending, and this the entire, especially if you are not able to separate out the needle, dispose into the puncture-proof container, and once 3/4 filled, you must dispose the complete container with the needles to the CTF. You're not supposed to empty it to some other container and hand it over. So complete container has to be given and it has to be replaced in the place. And container should be placed as close to the point of generation of your waste. So this is one another important thing for your standard precautions for safe injection. Next, we must also apply standard precautions for environmental cleaning. So whenever people are cleaning the environment, they must wear heavy duty gloves. As far as possible, use wet mopping and use disinfections as per the protocol. Again, the disinfections what we use, the strength should always be periodically monitored and see whether they are effectively done. Because if we are saying freshly prepared 1% sodium hypochlorite, it should be freshly prepared. If it's beyond that time, it may not be effective and it may not kill any organisms. And scrubbing during cleaning, they should be doing, and cleaning from top to bottom if you are cleaning the walls. So what are the types of cleaning solution we can use? Yeah. For removing just dirt and in low risk area, plain detergent solution will do. For surface disinfection, we use 5% chlorine, to which will kill organisms during cleaning. And disinfectant for cleaning, for highly contaminated, you have to use a higher strength, which could be hypochlorite solution or some other solution also. Next is spill management. How do we manage spill? Anybody can tell me? What is the practice you
Yes,
follow
ma'am.
in your hospitals?
For blood
Say
spill
there is a
management,
blood spilled on your table. How do you clean it?
first of all, we mark the area so nobody can visit this area,
Yeah.
and later we cover this spill with paper or any absorbent uh, or paper who it absorb this spill. Later we allow
Yeah.
the 1% hypochlorite solution on it according to the volume of spill is there. If it is less volume, then we can stay it for 15 minutes. If volume is high, then we can uh, leave it for 30 minutes. Later, we use all the PP and collect it in the yellow bag.
Very good.
Later,
What I suggest
later,
is, yeah, yes, sir. Very good, very good. What we suggest is whenever there is spill, when you clean the absorbent material, discard it off remove the spill as much as possible with your towel. Of course, cordon the area, put a sign mark, wear your complete PPE, then wipe the area with absorbent material and discard into the appropriate bin. So what I was trying to tell is remove as much as the place, because if you put a paper and again add the sodium hypochlorite solution, it may spread. Your area of cleaning might be increased. So clean the area as much as possible and discard into yellow bin. Then you cover the area with 1% sodium hypochlorite now as recommended. Yeah, or you can increase use a little more higher strength, no harm, because it's you are cleaning the surface disinfection, and allow it for at least 15 to 20 minutes, and then clean the area and discard all the PPE appropriate into appropriate color coded room. Very good. I can show you the video if we have time. I'll show
excuse
you.
me, ma'am.
Yes, yes, tell me.
But in slide there is 10% hypochlorite. I think it is
This was
1%
loading. It's
hypochlorite.
1%. It's 1%. You can increase little more to 5% because it's a surface disinfection. No harm. Okay. And next important thing is safe waste disposal. So our waste, what is to be disposed, to be rendered safe, and that is why some of the highly infectious waste like our lab waste and blood bags are rendered pre-treated before sending it to the CTF, and disinfection before recycling. So all our waste, probably I think we were all before using what is that sodium hypochlorite solution for needles, right? Collecting needles. I think that is still a good practice. If somebody is following, I do not say it is wrong. You can still follow it, because in the process you are going to disinfect till, because we are going to collect the needles for a longer period of time. We are not going to dispose the needle cans every day because it will be a costly affair. So you can still use sodium hypochlorite solution at the end of the thing. You can grab it and give it. Anyway, disinfection before recycling. All are red color waste and the blue waste which goes to the CTF are usually disinfected there using autoclave or any other methods, and then only sent for recycling. So that's about standard precautions, some of the standard precautions. We have what is called as transmission based precautions or specific precautions. That is like your contact precautions, drop. This is for the different procedure, the way mode of transmission. You can decide what measures you need to take. For contact precautions, you take hand hygiene measures, PPE, and surface disinfection. Similarly, for droplet, we use PPE, specifically face mask, even for the patients, hand hygiene, clean and disinfect room. So this was droplet infections, what precautions we were using in COVID areas, right? No, in airborne, we used airborne precautions like negative pressure room, HEPA filters, face mask, PPE, hand hygiene. These are all airborne precautions. And cough etiquette. This is basically to prevent airborne transmission, to cover, educate both the patients as well as the healthcare workers to cover mouth and nose while coughing and sneezing, and hygiene measures, and use surgical masks for those with respiratory infections, and have a maintained distance between two patients of at least 1 to 2 meters. So for eye transmission, we need to use goggles or face shield if you have to prevent eye precautions. So what are the more examples for contact infections? Isolation is essential. Gloves we have to use. Gown, that is like your MDROs, difficile infections, highly contagious skin infections. We have to use contact precautions. As much as possible, single use equipments to be used, and same precautions as for staff we must use. Like all the gloves, gown, mask, all should be worn when there are people are visiting in this contact transmission. For droplet infections like RSV, plague, meningococcus, we have to use gloves, gown, mask. Surgical mask is good enough, and eye protection if required if they are doing any procedure. And handling of equipment also must be careful. Visitors also has to follow the same as the healthcare workers. For airborne like pulmonary TB, SARS, which are highly contagious, we need to have negative pressure isolation and use N95 mask so that they do not get infection. Like COVID also, SARS, COVID and all, we have to use this uh, N95 mask, and also same thing for visitors as well. So essentially, we need to have different control measures to ensure worker and patient safety. Some of the we should have administrative for ensuring this reduction of hospital acquired infection. We need to have administrative controls, like we need to have infection control policies and procedures. We need to have facilities for barrier nursing, training, on job training and planning. We have to repeatedly training how to take care of catheters, how to take care of what is it uh, bundle branch care. Okay, how to take care of ventilators. So these trainings have to be happening repeatedly and on job as well. And engineering measures also we need to have. Water and sanitation, how do we ensure that the water we give is very free of pathogens. Hand hygiene infrastructure, that means you need to have washing facilities adequately and appropriate places so that it is easy for the healthcare workers to have practice it. We may say wash your hands, but the washing facility may be somewhere very far. It should not be like that. It should be very close to the area where we are close to the patient. Again, waste management facilities, you need to have the bins, adequate bins, trolleys for transportation, storage area, and ventilation. You need to have negative pressure rooms if required for SARS, and workplace control like practices. No recapping, no what to say, no bending, breaking. Those things you must tell, and also use of PP. So these are some of the measures which will also protect against the worker and patient safety, and also prevent the infection control. So I'll come to, so infection control precautions should be very clear. In different areas you need to have different focus, because each area has a different risk, and the chances of different hospital acquired infections can happen. So these are the some of the high risk zones we must be very careful, like OT wards, laboratory blood banks, and especially while handling sharps. And transportation, we need to have SOPs, precautions while handling spillage and accident. If there is major accidents like spillage of the waste trolley and some burns, those things are to be reported. I think as per our rules, you are all aware that if an accident occurs, it should be reported within 24 hours to the pollution control board and communicated immediately and reported. And PEP, post exposure prophylaxis, for this also, if there is an injury, we need to have a policy in place what to be done. So just a few think, when do we do post exposure prophylaxis? This is PEP is indicated based on the risk of infection, which is dependent on amount of blood, whether the virus is present in patient blood, and whether PEP is recommended. Okay. So what is to be done if an injury is happened? That should be washed with soap and water. I will demonstrate one video for this instead of going into the talking part. Let me show a video. I'll skip this part so that we can go through the video. What we need to know is first aid measure and reporting the incident and taking appropriate PPE. For all these things to happen, we need to have what is integrated infection prevention control management, which madam has already spoken. For this, we need to have a functional hospital infection control committee, for which the MS will be the chairperson, and member secretary of department of microbiology will be the any representative from microbiology can be member secretary. We need to have an NS, OT staff, and infection control technician. Even waste management can come part of it. HODs of all clinical department, because infection control should cut across all the departments. CSSD, linen, store, kitchen, sanitary, pharmacy. So we need to have represent. It's a big team, but it is important because whatever decisions have been will be taken here should percolate down to all the respective departments, and they need to practice them. So what are the major HICC activity? Is one is educating the people. HAI surveillance, that is a hospital acquired infection surveillance, is one of the important activity of HICC. Staff healthcare, how to manage needle-stick injury and vaccination program, and hygiene audit. They are responsible to see that whether our doctors, nurses are following. Bundle care audit, antimicrobial stewardship program, whether policy prescriptions, antibiotic prescription policies followed. Environmental surveys, check for water, air, surface, milk in major areas, especially in OT and ICU. And surveillance of staff for MRSA, so that they and antimicrobial resistance surveillance, and formulating disinfectant policy. What disinfectant we need to use for daily cleaning, for the instrument cleaning. All these things have to be discussed and debated in the HICC. And HII is one of the important activity. I'll just touch upon that. And this has to be done once a month, every time. And this is one of the important committee which is a part of our NABH accreditation as well. Now, what is HAI surveillance? HAI surveillance is a system that monitors the hospital acquired infections in the hospital. It provides baseline and endemic rates. It can help us to compare what is happening between our hospital and other hospitals. So it will help us to identify the problem and to correct, and so that it's one of the quality check mechanism also, and it will also help us give us the feedback to the clinicians. So usually we follow these four events which are there. That is the catheter COTI, CLAPSI, VAP, and surgical site infections. Usually the ICN will conduct this HCI surveillance, and this will help us in monitoring the system of hospital acquired infection. So the procedure here, we have to collect the data, analyze, interpret, and present during the HICC, and also disseminate to the others in the group. So we must also look at the safety measures for waste handlers, like hand washing facilities. I've told out, just repeating. PPE, precautionary measures, adequate training, emergency measures if any event of emergency happens, and safe transport of waste and disposal of infected waste. I'll skip this disinfection part. So conclusion is, As we are moving ahead, modern healthcare employs a lot of invasive methods, procedures to treat patients and help them recover. But in the process, they have the risk of getting hospital-acquired infections. And these hospital-acquired infections are threat to patient safety. If we do not take care of them, it will be very devastating. It will increase the cost for the patient as well as the hospital. And we need to keep a constant vigilance on these common HAIs which occur in our hospital, like your bloodstream infections, then ventilator associated pneumonia and SSI. And role of HICC in monitoring this surveillance of HI is very critical, and they need to meet frequently and see to that they keep these infections. They are not completely preventable, but definitely we can make measures to reduce these infections. Thank you very much. Any questions here? I'll go through the videos and then after that we can have question and answer session. Give me a minute.
Now we can ask questions.
Yeah. I'll just run through for spill management and PEP, needle stick injury management courses.
So any questions, students? Yes, Pravat Kumar, please ask.
Good afternoon, ma'am.
Yes.
What is that bundle care audit?
Bundle care means for this thing ventilators. How they manage those ventilators, that is called as bundle care.
Okay, so that there one audit should be done for that ventilator procedures.
Yeah, ventilator usually when we are, how do we put the ventilator, how frequently you have to monitor them, how frequently we need to change, all that is called as bundle care. So when a nursing care when she is doing, she will know, she'll notice all those things, whether it is in place, is there any contact infection is happening, all those things. Fine, 1 minute.
Thank you, ma'am.
Suman.
Any other question by anybody? Yes, TS, please ask your question.
Any questions?
Sir, how to track SSI after the discharge of the patient?
Yeah, usually what happens is usually SSI, especially surgical site infection, those who have gone surgery, they are the ones who usually come back. Especially any surgical patients, we must keep a track of patients who are post-op, who are coming back for any discharge in the wound and those things. Those cases can come up. Others, very unlikely, we might not get them. We might miss them. Just give a minute. Any other questions?
Yes, ma'am. One more question.
Yeah, please tell me.
Ma'am, in a sharp container, as you told, it is to be kept till it is three-fourth filled. And once we dispose after 7 days, along with the container, there will be sodium hypochlorite inside it. So they'll be how
No,
they'll be
no, one
carrying
minute.
it.
1 minute. Let me clarify to you. Actually, rules doesn't say you have to put what is that hypochlorite solution. If we are practicing, no harm is what I'm telling. It was one of the good practice was what I felt, but in the current rules they do not specify. So it's after three-fourth full filled up. Either you can empty that liquid and send it also, no problem, without causing any injury, or you can hand it over like that. Small amount of chlorine will actually rust the metals and it will be not usable, reusable. That is the concern.
So we can keep it dry
No problem. Until
inside.
unless you do not, there no access to anybody, there is no chance of injury. It's fine. No problem. It's not wrong.
If we put sodium hypochlorite, how they will be carrying it to the disposal place because it may spill somewhere.
No, no. Once you are filled up, it will be totally locked. No, it should be non-tamper proof. It should be locked completely. It should not be
Okay,
able to
okay.
spill edge actually.
Okay, with the container having that sodium hypochlorite and all salts, after locking it, we'll just hand over to the
Yes, yes.
person.
Yeah.
Okay.
And this you need not replace it every day because it is difficult to replace the hypochlorite solution. You can put once for all and then go on adding. At the end, once it is completely three-fourth filled, you would have put very little amount of sodium hypochlorite solution. Just that the chlorine will react with the metal and becomes non-usable. That is my intention, which I am proposing. This is not there in rules. If anybody asks for you for your reason, I got it. I got it. You got it. I'll play the blood spill 1 minute.
Thank you, ma'am.
What was your topic? Blood and body fluid spill management. Is the voice audible? Blood and body fluid spills need to be managed with utmost care to prevent exposure to infection. Every nursing station must contain a spill kit. The spill kit should contain disposable apron, gloves, mask, absorb. Sorry. Is the voice visible? I mean audible?
Yes, ma'am.
Blood and body fluid spill management. Blood and body fluid spills need to be managed with utmost care to prevent exposure to infection. Every nursing station must contain a spill kit. The spill kit
Only sound is coming. The video is not coming.
is it? 1 minute.
Yes, yes. Video is not coming.
Absorbent material, disinfectant, mop. Blood and body fluid spill management. Blood and body fluid spills need to be managed with utmost care to prevent exposure to infection.
No.
Every
Yes, yes.
nursing
Now it is coming.
spill kit. Okay. The spill kit. I'll play from beginning. Blood and body fluid spill management. Blood and body fluid spills need to be managed with utmost care to prevent exposure to infection. Every nursing station must contain a spill kit. The spill kit should contain disposable apron, gloves, mask, absorbent material, disinfectant, mop, yellow and red plastic bag. In an event of spill, the following steps need to be followed. Step 1. Cordon the area and place a caution board. Step 2. Open the spill kit and wear the personal protective gear. Step 3. Cover and clean the spill with a paper towel or any absorbent material and discard into yellow bag. Repeat the process if necessary. Step 4. Cover the spill area with sodium hypochlorite and wait for at least 20 minutes. Step 5. Wipe the area with paper towels and dispose them into the yellow plastic bag. Step 6.
Clean and mop the area as per regular
And the
housekeeping.
video has been paused.
Step 7.
It has been
Remove
paused.
the personal protective
Yes,
equipment.
ma'am. Now it's moving. Now it's moving, ma'am. Can you just repeat step
Step
5?
8.
From
Wash
where?
your hands. 5.
It goes off completely.
Blood and cover. 5. Process if necessary. Step 4. Cover the spill area with sodium hypochlorite and wait for at least 20 minutes. Step 5. Wipe the area with paper towels and dispose them into the yellow
Video
or
is not coming, ma'am.
Step
It's
6.
not coming.
Clean
No. Yeah, it has come now.
It's coming.
and mop the area as per regular housekeeping practices. Step 7.
Sound
Remove
is
the
too low. Please increase it.
plants and dispose it appropriately. Step 8. Wash your hands. Finally, refill the spill kit for the next use.
One more, I'll just run through. Occupational safety, I'll run through.
Occupational safety. Healthcare personnel and workers handling waste may encounter hazards and infection risks as a result of their occupation. It is therefore necessary to prevent and control these risks. All healthcare facilities have a responsibility to ensure the occupational safety of healthcare personnel. An occupational safety program should include provision of personal protective equipment, regular health checkup of all healthcare workers, immunization, management of accidental exposure to blood and body fluids, training, and documentation. Personal protective equipment. Personal protective equipment are specialized clothing or equipment which act as barriers against infectious materials. It should be made available to all personnel who collect or handle waste. The following are to be used by all those who handle biomedical waste: cap or head cover, mask, goggles or face shield, gown, gumboots, and heavy duty gloves. Regular health checkups. According to Biomedical Waste Management Rules 2016, all healthcare personnel, including waste handlers, must be provided a medical checkup at the time of induction and thereafter once a year. Immunization. All healthcare personnel should be immunized with hepatitis B vaccine and tetanus toxoid. Management of accidental exposure to blood and body fluids. Remember, recapping is a wrong practice. It can lead to needle stick injuries. Occupational exposures to blood and body fluids can also occur through spills and splashes into the eye or mouth. When such an occupational injury occurs, do not panic. Do not put the finger into your mouth. Do not squeeze the blood from the pricked finger. Do not apply any disinfectant. What you should do is remove gloves and place hands under running water for 5 minutes. Collect blood from the source and the exposed person and send it to the lab for HIV and hepatitis B testing. Record details of the event and its follow up in the injury register maintained at the hospital. Start post exposure prophylaxis for HIV, preferably within 2 hours and not later than 72 hours. The exposed person must also be provided with psychological support by a counselor. Training. All healthcare personnel and waste handlers should be trained on biomedical waste management on an annual basis.
Thank you. Any questions?
No, ma'am.
Yeah.
If there is no question, we can conclude now, madam.
Yeah.
So,
Fine. I think hospital-acquired infections, as we have told, and hygiene. We thought we will have a demonstration. Shall we go ahead?
yes, you can go ahead. Whatever
Yes.
activity that you
Can
want to
I
do.
request all of you to put on your videos also?
Please switch on your video. I think many people have left. Only 12 people are present.
Okay, it's okay. We'll work with them only. No issues. Are we ready?
Please open your video. Surendra Saini.
We'll all do this and hygiene. We'll start. So first we'll have soap and water if required. Then we'll go palm to palm, right palm, okay, and then palm on the back of the arm. Same repetition on the other side also. Okay, and then knuckles, covering all these things. Then thumb, right thumb, sorry, knuckles, sorry, both the sides. Then thumb, right thumb, left thumb. Then comes your fingers, right hand, then left hand, and then wrist and wash. Okay. Thank you very much. Thank you, sir.
Thank you, ma'am.
So thank you very much for so nicely presenting the topic
Thank you,
today. And I think our learners must have been benefited immensely out of the presentations made by you. So, madam, once again, I thank you. And tomorrow there is another session. Students, please tell your friends to join in large numbers because only few students are coming. Because we are organizing sessions for you. If you do not turn up, definitely it is your loss. We are taking so much of pain. Our experts are coming from
Can you
different
share the
places
video?
with their respective institutions and presenting. So,
Video is heavy. Actually, it was there on the website. Now it's removed. If you can mail it to me, I will try to send it across the link for you.
Okay, thank you.
I will write.
okay.
Please, you can write to this mail. Put in the chat box.
Okay, ma'am.